Hello everyone in CardioMind's channel, and today we are having the last video in the guidelines of cardiovascular management of patients undergoing non-cardiac surgery. And as we dealt with preoperative consultation, we dealt with handling antithrombotic medications and the preoperative complication. Today we are speaking about consultation for specific cardiovascular diseases. Let's start with coronary artery disease. This diagram illustrates how to deal with ischemic patients scheduled for non-cardiac surgery. If your patient has acute coronary syndrome, so you should optimize his or her guideline recommended medical therapy and then follow the same diagnostic and therapeutic pathway as in the guidelines of acute coronary syndrome. Then, an interdisciplinary discussion between the cardiologist, surgeon, and anesthesiologist regarding the myocardial revascularization option and the need for surgery and what would be the strategy for antithrombotic should be performed to show what is the priority for the surgery or for revascularization at first. If your patient has chronic coronary syndrome, so you should also optimize the guideline recommended medical therapy, then ask yourself, if the surgery is low risk, so no further screening is needed. But if it is intermediate risk, you should perform clinical examination, ECG, biomarkers, and assess his functional capacity. If the patient has symptoms suggestive of ischemia, abnormal ECG, poor exercise tolerance, or elevated biomarkers, in this case, should arrange for transthoracic plus-minus stress imaging to assess the magnitude of ischemia. And if the patient has elevated troponin or stress-induced ischemia, in this case, we may arrange for invasive coronary angiography plus-minus IFR or FFR. Otherwise, just keep on conservative treatment and go for the surgery. If the patient is scheduled for high-risk surgery, so we should also perform the same clinical examination, ECG, biomarkers, and functional capacity, followed by transthoracic plus-minus stress imaging, as here it is a must because the patient is scheduled for high-risk surgery. And if the patient is having symptoms, abnormal ECG, poor exercise tolerance, or elevated biomarkers, so we should also go for invasive coronary angiography plus-minus IFR or FFR. Otherwise, keep on the conservative treatment and go for surgery. Multiple trials address the issue of myocardial revascularization before elective non-cardiac surgery. CAST trial found that CABG reduced the risk of perioperative mortality and MI in patients undergoing major surgery, especially in those with cerebrovascular disease, and reduced ejection fraction. However, the evidence to support routine prophylactic coronary revascularization before surgery is based on just small clinical trials and retrospective registries, not representative of the current clinical practice. The CARP trial randomized 510 patients with chronic coronary syndrome to either optimize medical therapy or coronary revascularization before major vascular surgery, and they found no significant difference regarding acute MI after 30 days and mortality after 2.7 years. However, this study excluded those with significant left main disease, and only 1/3 of patients had 3 vessel disease. Ischemia trial randomized patients with a stable coronary artery disease and moderate or severe ischemia to either initial invasive strategy from the start or initial strategy of medical therapy alone and then peel-out angiography if medical therapy failed. And there was also no significant difference in the primary composite endpoint of death and MI between both treatment groups. However, patients with severe left main disease were excluded after pre-randomization CT coronaries, so they excluded the high-risk patients, and a large angiography-based registry of chronic coronary syndrome patients with high-risk coronary anatomy like cerebrovascular disease and 70% stenosis in all 3 epicardial vessels, or left main disease with more than 50% stenosis, showed reduced outcomes in patients undergoing revascularization, either PCI or CABG, in comparison with the conservative medical therapy. So it is a controversial issue regarding preoperative coronary revascularization. That's why an interdisciplinary risk assessment between cardiologist, surgeon, and anesthesiologist is needed to assess the ischemic risk if the patient proceeded for surgery without revascularization, and what would be the bleeding risk if the patient had revascularization and he is going to receive antithrombotic therapy perioperatively. So the recommendations for chronic coronary syndrome patients that if PCI is indicated before surgery, the use of new generation drug-eluting stents is preferred to bare metal stents or balloon angioplasty, as the rate of reocclusion in restenosis is lower and it needs shorter duration of dual antiplatelet therapy, and preoperative evaluations of patients with an indication for PCI before elective surgery should be performed by an expert team of a surgeon and a cardiologist. Myocardial revascularization before elective high-risk surgery may be considered depending on the amount of ischemic myocardium, presence or absence of refractory symptoms, and the finding at coronary angiography, whether there are high-risk finding or not, but it is class 2B, and the big no that the routine revascularization before low or intermediate risk surgery is not recommended. We need to have meticulous clinical assessment to assess the ischemic risk before that. In acute coronary syndrome patients, if the surgery can be postponed for at least 3 months, so we should follow the same diagnostic and therapeutic interventions as in the acute coronary syndrome guidelines. And if there is unlikely combination of life-threatening clinical condition needing urgent surgery and non-ST elevation acute coronary syndrome indicated for revascularization, then the priorities for surgery versus coronary revascularization should be considered by an expert team to assess the priority is for which one of them. Let's now move to chronic heart failure patients scheduled for non-cardiac surgery. Those patients need to have assessment of the volume status and signs of adequate coronary perfusion because they are at increased risk of acute decompensated heart failure or mortality during surgery, and the presence of heart failure itself increases the all-cause mortality compared with its absence, and patients with heart failure who are decompensated are at higher perioperative mortality risk compared with compensated patients. So patients with suspected or known heart failure scheduled for high-risk surgery need to evaluate LV function by echocardiography and measure the biomarkers unless it is recently performed, and the echo should not be older than 6 months, or it should be performed just before surgery in case of clinical worsening, and those patients should receive optimal medical therapy according to the most recent ESC guidelines of 2021. And as we remember from the first videos, that beta blockers and statins should be continued in those patients as they are having strict indication without interruption perioperatively, and patients with stable heart failure may continue with RAS inhibitors perioperatively. So in order to reduce the risk of perioperative acute decompensation, the patient should start or continue his optimal guideline-directed medical therapy, monitor the fluid balance. Invasive monitoring of blood pressure is needed for intermediate or high-risk surgery, and in specific situations, right heart catheterization or transesophageal echo intraoperatively may be considered. We need to follow up ECG and cardiac biomarkers for early detection of perioperative MI and perform follow-up echo post-operatively in case of acute decompensated heart failure. Now the large group of valvular heart disease. Those patients who have known or suspected valvular heart disease should have clinical and echocardiographic evaluation, if not recently performed, before elective intermediate or high-risk surgery due to the high risk of perioperative complication in these situations. This diagram illustrates how to deal with severe aortic stenosis scheduled for elective or time-sensitive surgery. Those patients should have clinical examination, ECG, biomarkers, transthoracic echocardiography, plus-minus TEE in some situations, and receive optimal guideline-recommended medical treatment. Then, multidisciplinary consultation. If the patient is symptomatic and scheduled for low-risk surgery, we need to assess his risk for valve procedure. If it is low risk, so we need to have an individual decision whether he needs valve procedure before surgery. But if the valve procedure is high risk, so we would go for the non-cardiac surgery without additional procedures. If the patient is scheduled for intermediate or high risk surgery, so we would ask ourselves again, is the patient at high risk for valvular procedure or not? If it is low risk, so heart team should discuss whether the patient would need TAVI or surgical aortic valve replacement. If it is high risk, so it would be risky to proceed with the non-cardiac surgery before valve intervention, so we may consider balloon aortic valvuloplasty before the surgery or perform the non-cardiac surgery under strict monitoring. What if the patient is asymptomatic? This may be relatively reassuring. In this case, we need to assess the LV ejection fraction. If it is preserved, so non-cardiac surgery can be performed without additional procedure, but if it is impaired and the patient is scheduled for low or intermediate risk surgery, so we can proceed with the surgery, but in case of high risk non-cardiac surgery, we need to assess again the risk of the valve procedure. If it is low risk, so discuss with the heart team the need for TAVI versus surgical aortic valve replacement. If it is high risk, consider balloon aortic valvuloplasty as we mentioned before, or proceed with the surgery under strict monitoring. So the recommendations that aortic valve replacement is recommended in symptomatic severe aortic stenosis scheduled for intermediate or high risk surgery, and asymptomatic severe aortic stenosis scheduled for elective high risk surgery, especially if there is LV dysfunction, should be considered to have surgical replacement or TAVI after heart team discussion. In case of patients with severe symptomatic aortic stenosis needing time-sensitive surgery like cancer surgery and the TAVI or surgery are unfeasible, in this case balloon aortic valvuloplasty may be considered before surgery as a bridge to the definitive aortic valve intervention. And the opposite, aortic regurgitation. Patients with symptomatic severe aortic regurgitation or asymptomatic severe but LV in systolic dimension more than 50 mm or in systolic dimension index more than 25 in patient with a small body size, or resting LV ejection fraction less than 50 or equal. In this case, valve surgery is recommended before elective intermediate or high risk non-cardiac surgery, and of course it makes sense. What about mitral regurgitation? Patients with symptomatic severe primary mitral regurgitation or asymptomatic severe with LV in systolic dimension more than or equal 40 mm or ejection fraction less than or equal 60%, because we know here that ejection fraction is overestimated with severe mitral regurgitation due to afterload mismatch, valve intervention, either surgical or transcatheter, should be considered before intermediate or high risk non-cardiac surgery if time allows. It follows nearly the same principles as in aortic stenosis and aortic regurgitation. This diagram illustrates how to manage severe secondary mitral regurgitation in patients scheduled for non-cardiac surgery. If the surgery is elective or time sensitive, both need clinical examination plus ECG, biomarkers, transthoracic echocardiography plus minus TE. The elective surgery group should receive optimal medical treatment including CRT if indicated, plus minus myocardial revascularization as the time here allows, but in time-sensitive surgery, just start the medical treatment and multidisciplinary consultation. Then ask yourself, is the patient having refractory symptoms despite medical treatment? If the answer is no, so proceed with surgery, but under strict monitoring. If the answer is yes and the surgery is low risk, so no additional procedure. If the surgery is intermediate or high risk surgery, so transcatheter or surgical repair is needed depending on the eligibility and according to the decision of the heart team. If the patient is considered to be inoperable or at high procedural risk, so consider the surgery under strict monitoring. So the recommendations that patients with severe secondary mitral regurgitation who remain symptomatic despite guideline-directed medical therapy including CRT, valve intervention either transcatheter or surgical, should be considered before non-cardiac surgery, especially for intermediate or high-risk surgery. And the opposite, mitral stenosis. Patients with moderate to severe rheumatic mitral stenosis and symptomatic or having pulmonary hypertension, valve intervention, either percutaneous mitral commissurotomy or surgery, is recommended before intermediate or high-risk surgery. Here, the non-cardiac surgery can be performed with low risk of complications in patients with mild mitral stenosis or asymptomatic with moderate to severe mitral stenosis and the pulmonary pressure less than 50. Otherwise, valve intervention is needed. and please try to avoid increase in heart rate or vasodilators beside fluids overload. What about patients with arrhythmias scheduled for non-cardiac surgery? We are having the same principles as in the guidelines regarding SVT, and we would consider catheter ablation if recurrent despite optimal medical therapy before high-risk surgery. Idiopathic VT in structurally normal heart, the same principles. VT in structural heart disease, in this case the catheter ablation may be indicated if recurrent despite optimal medical therapy before any type of surgery due to the high risk of developing tachyarrhythmias perioperatively. And in all these situations, you need to identify and correct potential triggers, especially electrolyte, acid-base imbalance, or volume overload, or even dehydration. So patients with SVT controlled by medication, we need to continue the antiarrhythmics perioperatively, and ablation should be considered in case of recurrent or persistent SVT despite treatment before high-risk non-urgent surgery. Patients with AF and hemodynamic instability, emergency DC cardioversion is recommended, and amiodarone may be considered for acute rate control. Patients due to scar-related monomorphic sustained VT, which is recurrent despite optimal medical therapy, should have ablation before any elective surgery, and the big no that it is not recommended to initiate treatment for just asymptomatic PVCs during non-cardiac surgery. Regarding bradyarrhythmias, the same indications for cardiac pacing according to the 2021 guidelines should be followed before surgery. So if this patient is indicated for permanent pacemaker implantation, it should be performed as a priority before the non-cardiac surgery. Patients with cardiac implantable electric device, either pacemakers or ICD, represent a big challenge perioperatively. Those patients should be reprogrammed before surgery, having a recheck and necessary reprogramming as soon as possible also after the procedure. And in high-risk patients like ICD or pacemaker dependent undergoing surgery and a high risk of electromagnetic interference due to, for example, electrocautery above the umbilical area, in this case the checkup and necessary reprogramming should be performed immediately after. Regarding the electrocautery, it is rare to develop electromagnetic interference if the bipolar cautery is used more than 5 cm from the device or unipolar below the umbilicus. And in order to reduce this risk, as much as you can use bipolar cautery, if you are obliged to use a monopolar cautery, so it should be applied in short pulses with the lowest effective energy with the skin patch away from the area of the device. If the patient is pacemaker dependent, so a magnet should be applied during delivery of diathermy or cautery to prevent oversensing and to stop rate responsiveness. And if the patient is having intrinsic rhythm more than 50 beats per minute, so no need for magnets or to program it to asynchronous mode to avoid RONT phenomena, especially if the surgery site is far from the device. If it is an ICD, so therapies need to be stopped in presence of possible electromagnetic interference to avoid inappropriate ATB or shocks, either by programming or by putting a magnet during surgery. After we finish the major cardiovascular disease group, let's speak about some miscellaneous examples. Patients with adult congenital heart disease are a variable group varying from minor risk defects to intermediate to severe or high risk defect like uncorrected cyanotic heart disease, patients with pulmonary hypertension, complex congenital heart disease, ventricular dysfunction, or patients listed for heart transplantation. That's why in those situations, a consultation with a specialist in adult congenital heart disease is recommended before intermediate or high-risk surgery to perform risk assessment, and those patients need to be performed in a center with an experience in the care of adult congenital heart disease. Some of them have a lifelong indication for oral anticoagulation therapy due to specific arrhythmias like atrial fibrillation or tachycardia, or increased thromboembolic risk due to pulmonary hypertension, so the oral anticoagulation therapy in the perioperative phase should be re-evaluated to assess whether we would need to have bridging with parenteral anticoagulation or not. Also, antibiotic prophylaxis for endocarditis should be given according to the 2015 ESC Guidelines, at those patients if they are having cyanotic congenital heart disease or any type repaired with a prosthetic material, whether placed surgical or percutaneous, up to 6 months after the procedure, or in some cases lifelong if residual shunt or regurgitation is present, need to have antibiotic prophylaxis. And please kindly note some of the high-risk group like chronic cyanotic patients that are associated with multi-organ involvement and higher bleeding risk due to collaterals, platelet dysfunction, and coagulopathy. Post-Fontan patients have intra-abdominal pressure rising too high, like in laparoscopy, may result in drastic reduction in venous return and drop in cardiac output. And Eisenmenger syndrome patients, we should avoid condition increasing pulmonary vascular resistance like hypothermia, acidosis, hypercapnia, or hypovolemia. Regarding patients with acute pericarditis, we should postpone the elective surgery till complete resolution of the underlying pathology and try to avoid elective surgery under general anesthesia till colchicine or immunosuppressive therapy is completed, because colchicine increases sensitivity to seen as depressants, resulting in respiratory depression, and it may cause diarrhea, worsening renal function, rarely to cause bone marrow suppression, hepatotoxicity, convulsions, or cardiopulmonary collapse. And of course, immunosuppressive drugs increase risk of infection and may delay wound healing in perioperative phase. That's why it is better to finish the treatment course and then arrange for the surgery. Regarding pulmonary hypertension, there are some risk factors related to the patients that may increase perioperative risk, like functional class more than 2, reduced 6-minute walk test, coronary heart disease, previous pulmonary embolism, chronic renal insufficiency, or severe RV dysfunction, and some surgery-related factors like emergent surgery, duration of anesthesia more than 3 hours, or intraoperative requirement for vasopressors. The recommendation is to continue chronic therapy for pulmonary arterial hypertension in the perioperative phase, and hemodynamic monitoring in patients with severe pulmonary hypertension should continue for at least 24 hours. Sometimes invasive monitoring is needed, and in case of progression of right-sided heart failure in the post-operative phase, it is recommended that diuretics be optimized, and in some cases intravenous prostacyclin analogs may be initiated under the guidance of the physician. And class 2A, that anodilator drugs like dobutamine, milrinone, or levosimendan may be used to increase cardiac output and decrease pulmonary vascular resistance according to the hemodynamic status of the patient. One of the most common diseases to be present in patients scheduled for surgery, representing a big dilemma, is systemic hypertension. In those patients, we should avoid large fluctuations in blood pressure perioperatively, especially hypotension, with an approach that intraoperative systolic blood pressure should be kept within 10% difference from the preoperative values to reduce risk of post-operative organ dysfunction. And it is recommended to perform preoperative screening for hypertension-mediated organ damage and risk factors in newly diagnosed hypertensives who are scheduled for high-risk surgery. And the big no is that you should not postpone surgery in patients with stage 1 or 2 hypertension. You may postpone till control of blood pressure in patients with grade 3 hypertension, systolic blood pressure more than or equal 180, and diastolic more than or equal 110, one or both of them, till control of blood pressure. And as you remember from the first videos that in patients without heart failure, mostly we are speaking about hypertensive patients, we can withhold RAS blockers on the day of surgery to avoid perioperative hypotension and avoid diuretics also on the day of surgery to reduce risk of dehydration or electrolyte imbalance. Patients with peripheral arterial disease and poor functional capacity or significant risk factors or symptoms should be referred for cardiac workup and optimization before elective surgery. Pain control is crucial to reduce sympathetic stimulation to ensure stable blood pressure control and minimize risk of aneurysmal rupture. And patients with large abdominal aortic aneurysm should be evaluated for repair, preferably by EVAR before non-vascular, non-cardiac surgery. There are some evidence for starting low-dose rivaroxaban and aspirin within 10 days after lower limb revascularization procedure to reduce post-operative thrombotic events like acute limb ischemia, amputation, MI, stroke, and cardiovascular death. And the big no in peripheral arterial disease that routine referral for cardiac workup, coronary angio, or cardiopulmonary exercise test before elective surgery for peripheral or abdominal aortic aneurysm is not recommended, as there are specific indications to refer the patient in presence of significant cardiac risk factors or symptoms. In patients with cerebrovascular disease, preoperative carotid artery or cerebral imaging is recommended in patients with history of TIA or stroke in the previous 6 months and they have not undergone ipsilateral revascularization. And patients with carotid artery disease undergoing surgery, we are following the same indications for carotid revascularization as for other patients not scheduled for surgery. And the benefit of revascularization is high in patients with recent TIA or stroke within 3 months or more than 70 or equal carotid stenosis. So it should be performed first and then perform the elective surgery after revascularization. And as we expect, preoperative carotid imaging before surgery is not a routine procedure. As we mentioned here, there are specific indications to perform it and to arrange for revascularization. As we learned before, that CKD is defined as abnormalities of kidney structure or function present for more than 3 months with health implication, with the criteria is albuminuria in spot urine specimen or GFR less than 60, and GFR can be estimated also from CKD epidemiology collaboration equation besides the calculation of creatinine clearance to risk stratify the patient. So in patients with risk factors like age more than 65, body mass index more than 30, diabetes, hypertension, hyperlipidemia, cardiovascular disease or smoking, undergoing intermediate or high-risk surgery, we should screen for preoperative renal disease by assessing serum creatinine and GFR. Contrast-induced acute kidney injury, or as we famously know as contrast nephropathy, is defined as rise in serum creatinine following contrast administration of a magnitude of 44 millimole or equivalent to 0.5 milligram per deciliter, or 25% relative increase from the baseline at 48 hours, or 5 to 10% increase at 12 hours. It usually occurs in about 15% of patients with CKD who are undergoing radiographic procedures, and most cases are self-limiting, returning to the normal within 7 days, but in some cases, like about 0.5 to 12%, they may develop overt renal failure. So in those patients who required contrast-enhanced radiography and they have already renal disease, we should have balanced hydration with IV isotonic fluids, use the minimal volume of contrast media, and better to be low osmolar or iso-osmolar contrast to reduce the risk of contrast nephropathy. And cystatin C measurement can be used for risk stratification in patients with impaired GFR like less than 60 to confirm kidney disease. Obesity is usually missed during preoperative assessment as a risk factor for perioperative morbidity or mortality. We usually define it as body mass index more than 30 kg per meter square, morbid obesity is more than or equal 35, and supermorbid obesity defined as more than or equal 50. It is recommended in obese patients to assess cardiorespiratory fitness, which is usually measured by the peak oxygen consumption to estimate the preoperative cardiovascular risk before intermediate or high-risk surgery, as it refers to the ability of the circulatory and respiratory system to supply adequate oxygen to the skeletal muscles during activity. So cardiorespiratory fitness is as important as assessing the body mass index, and in patients at high risk of obesity hypoventilation syndrome, additional investigation may be needed before major elective surgery. Diabetic patients or with impaired glucose tolerance, we should have preoperative hemoglobin A1C if not performed in the last 3 months, and in case of hemoglobin A1C more than or equal 8.5%, we are speaking about uncontrolled diabetes, so we should postpone the surgery to reduce any risk of perioperative morbidity or risk of wound infection. In those patients, we should assess for presence of suspected or known coronary artery disease, autonomic neuropathy, retinopathy, or renal disease before intermediate or high risk surgery. And as we know from the first video that patients on SGLT2 inhibitors should stop it at least 3 days before intermediate or high risk surgery to reduce the risk of euglycemic DKA. So we have reached the end of the last video in the guidelines, and our take-home message today that the same recommendations that we discussed in the first video are followed in general for all patients regarding cardiovascular preoperative risk assessment and tools. With meticulous history taking and examination, we should be oriented about any specific cardiovascular or non-cardiovascular diseases that may modify our approach, whether they will need specific medications, intervention before the surgery, or specific assessment tools. So it is not a unified reply for all preoperative consultation the presence of a specific disease should nullify our recommendations. Thank you very much for watching the last video in the guidelines of preoperative assessment, and we are going next to another guidelines recently published this year.